Hi, my name is Dr. Jerry Hesch, a physical therapist at the Hesch Institute in Aurora, Colorado, where we provide treatment for patients with chronic pain, especially sacroiliac joint dysfunction, and use a whole body context of treating that. And we also provide continuing education via home study and teaching workshops. The title of this presentation is How I Came to Discover New Patterns of Sacroiliac Motion Dysfunction. And for a definition, we will state that SI dysfunction, sacroiliac joint movement dysfunction, which we'll refer to as SIJD in the future, is defined as either a hypomobility, otherwise a blocked motion of going through the pelvis, or a hypermobility, a significant increase in mobility. And again, this relates to motion going through the pelvis when evaluated with joint stress tests. So on the model pelvis here, I will give you an example of a joint stress test. If we palpate across the entire length of the pubic joint, the upper, middle, and lower portions, and we find a distinct step down such that it appears that the left pubic bone has shifted posteriorly. If you follow that pubic bone and you get the person supine, you'll find that right behind it is the ischial bone, okay? And of course, ischium is fused with pubic bone. Ischium is fused with the upper ilium as well. And so if we lay that person prone and we push on that ischium with at least 15 pounds of pressure to attempt to take up the slack, we'll find that it's stuck and doesn't yield. And when we impart an additional 15 pounds of force to try to get movement in that structure, we find that it doesn't move. Whereas if you come to the other side, you'll find a little bit of movement when you take up the slack with about 15 pounds of force, and you'll find that then holding it in that manner and then thrusting it, after that you'll find it moves and it recoils, it bounces back just like a shock absorber. So using this example, if we were to do a spring test on the pubic bone, it would be a lot less force. By design, it's a simple joint and it doesn't require much force. And so you can do a spring test on the ischium with the outside of the hand, and you can do it with less than 10 pounds of pressure. And what you would find in that example is that you would be able to take up the slack and you would be able to spring it, and that it would move excessively in comparison to a norm and in comparison to the other side. So that serves as an example of what a spring test is. And in the example of the pubic joint, you can again see that there's a step off, and so there is a movement dysfunction in the pubic joint per se. But the sacroiliac joint is a much more complex joint, and it's very deep in the pelvis, and there are many external factors that can alter movement in the sacroiliac joint. So when we do spring testing on the ilium, for example, or vertically through the ischium or directly on the sacrum, we cannot state that we are isolating movement only in the SI, but we can state that we are evaluating movement that goes through that joint. In using a detailed evaluation of palpatory landmarks touching different parts of the bony pelvis, additional patterns of static posture were encountered. With a traditional palpation, typically the ASIS is palpated for anterior-posterior position and for superior-inferior. And to that, I also palpate what I call the anterior iliac shelf, that flat portion right above the ASIS. I also palpate this flat portion of the ilium right in the middle, which I name the posterior iliac shelf. Research shows that when people try and palpate the iliac crest, some do it from facing the patient, some do it from behind, but what the research shows consistently is there's very poor intertester agreement. There's good intertester agreement with the palpation that I use, as has been researched by Olson, and that was a master's thesis and has been presented at several conferences. I also palpate the middle of the sacrum, which is in addition to the traditional landmarks. Traditionally, the PSISs are palpated, the top of the sacrum called the base, and then also the infralateral angles, both for anterior posterior positioning and also the inferior, underneath the inferior lateral angle. I also palpate the mid-sacrum at about S2 and also at S3, 4 areas. And so I'm using a few additional landmarks. And in addition to palpating under the ischial tuberosities, as per the tradition, I also palpate medial to that and compare that distance to the midline crease of the gluteals. Ligament palpation is also important, and so we palpate ligaments for tone, especially the big sacrotuberous ligament and also the somewhat horizontal sacrospinous ligament. So a few more palpatory landmarks gives us a little bit more information about making a comparative study of the pelvis from side to side. But going beyond palpation is movement testing, and we've already given one example of a spring test. And the passive joint stress tests are also named spring recoil tests, because you take up the slack, spring it forward, and you appreciate the recoil, the quality or the absence thereof. And the traditional patterns of movement dysfunction of the pelvis have been described many times by many in the physical therapy literature and certainly in the osteopathic literature and chiropractic as well. And if you read those and you compare them to the landmark article published in 1958 by Fred Mitchell Sr. in the American Academy of Osteopathy, you'll find out that creates a common theme, that all publications after that reflect those writings with some subtle changes, some subtle differences, but that 1958 article is the landmark article where the breadth of types of sacroiliac movement dysfunction, pelvic joint movement, pelvic movement dysfunction were described. And there's many authors out there. There's Vicky Sims, there's Dick Don Tigney, Chad Cook, Philip Greenman, and if we go down to my library in the basement, we'll show you many, many more books where there are chapters on the pelvis and books dedicated only to sacroiliac joint dysfunction. And I have a couple of book chapters as well, and a book which you can find on Amazon that I wrote. And so there are traditional patterns that they describe, and they describe it from the belief that the ilium moves on the sacrum, or that the sacrum moves on the ilium. And it moves such a small amount based on many very, very good research studies that the excursion of the pelvic landmarks is much greater than the motion that is inside the joint. So we really can't say that we're isolating movement inside the sacroiliac joint when we do these movement tests. But we can say that movement is traversing through that structure. And that's a significant point and a very relevant to the Hesch model of evaluating sacroiliac joint dysfunction. I also have a couple of YouTube videos where I show that the spring testing can be completely blocked on one side of the body in a person who has a fusion of the sacroiliac joint. One of them had a breach of hardware for scoliosis surgery, and on one side that hardware extended down to the lower sacroiliac joint, and all motions done on that side of the pelvis were blocked. I have another YouTube video where we have a person who, interestingly, was the first avian bird flu virus. I guess that's probably redundant, avian and bird are redundant terms, but the bird flu virus person, the first case in the United States. And he happens to be a physical therapist and had a severe viral insult, weakened his immune system, turned into a bacterial infection which invaded his sacroiliac joint. And you can see his MRI and CAT scan images, and that joint space is obliterated. It is fused solid, and you can see how all the spring tests done on that side of the body do not have that normal give when you take up the slack. There's no spring mobility when you try and thrust it. So moving on, I'll mention briefly that typical patterns described in the literature are anterior ilium, posterior ilium, upslip of the ilium, inflare of the ilium, outflare of the ilium, and movements of the sacrum such as a forward bent sacrum, backward bent sacrum, and also sacral rotation and sacral torsion, which is a combination of rotation and side bending. Those are typical terms that you will encounter in the literature, and in Don Tigny's writings he writes about an anterior ilium with an upslip and also bilateral anterior ilium. And the Hesch model accepts those patterns with a little bit different interpretation, such that the whole pelvis can be involved in a movement pattern blocking movements, making it appear as though the ilium rotated anteriorly, as an example. The Hesch model has a much more realistic interpretation, because I don't believe I can isolate just a very tiny amount of movement in the joint. But I believe that we can evaluate whether or not movement goes through that joint. In addition to the patterns of movement in the traditional model in the SI, there are also patterns in the pubic joint, such as describing an upper pubic joint rotation, but the Hesch method states that that doesn't really exist. When a clinician describes an upper pubic rotation, if they were to palpate the middle and lower part of the joint and do the spring test, they would find it's actually a glide. It's a posterior glide. So the Hesch model denies the existence of an upper pube rotation, but the Hesch model does acknowledge a lower pube joint rotation where the asymmetry is greatest at the lower part of the pube, fairly symmetrical mid and symmetrical upper joint. And the Hesch model defends the existence of a downslip of the ilium. The traditional model states that a downslip of an ilium, which the ilium purportedly slides down on the sacrum and gets stuck, occurs commonly, but with gait it moves back up and self-corrects. And the Hesch model says that that's not really valid, because downslip patterns are encountered in the clinic with doing this method of palpation and spring testing, these joint stress tests, and that during gait, the appropriate direction of force to reduce a downslip of the ilium does not happen during gait. And on my website, the Hesch Institute website, at the very bottom you see a very relevant example of downslip in a young child and a dramatic response to treating that. So the Hesch model does describe 15 novel patterns of sacroiliac joint dysfunction. And I will give a name to each of those, and in a separate video I will film a more detailed description of those. But I would like to add that the Hesch model also denies the existence of what the osteopathic model describes as a unilateral flexion or a unilateral extension of the sacrum. If you understand what a sacral torsion is, those patterns are just like a torsion, except side bending would occur in the opposite direction, and that would require profound instability in that joint, such that that person would not be ambulatory. And I've looked and looked using more detailed palpation and more spring testing, and I simply do not find those patterns in the clinic. So I will just quickly name the 15 patterns that are unique to the Hesch model, and this is perhaps the most significant biomechanical reinterpretation of sacroiliac joint mechanics or pelvic mechanics since the 1958 article. And so the first pattern is I have named posterior glide of the pubic bone. lower pubic rotation, posterior glide of the pubic fibrocartilage, side bent ilium, posterior glide fixation of the sacrum, bilateral inflare, anterior glide of the sacrum, type 1 inflare in contrasting that with type 2 osteopathic inflare, and same with the type 1 outflare in contrast with what I call the type 2 osteopathic outflare, oblique upslip of the ilium, oblique downslip of the ilium, lateral ischium, which is actually the hemipelvis and the hip, in which the positioning demonstrates a difference between the medial aspect of the ischium and midline of the gluteal crease. And all of these require an alteration in mobility with the spring testing. Medial ischium, lateral rotation of the ischium, and of course that's actually the entire pelvis, hemipelvis, and the hip being involved, and medial rotation of the hemipelvis / ischium. And I say ischium because that's where it becomes most apparent. So when I spring an ischium and it doesn't have any give, it doesn't spring medially, then I name that a lateral ischium based on the palpation, based on the spring test mobility testing. And then the other one is pelvic side glide. And so that is 16 patterns which are unique to the Hesch model, which are not described in the osteopathic, not described in the physical therapy literature. The Hesch model also has reinterpreted the biomechanics of pubic symphyseal diastasis, such as during a traumatic birth, in which the pubic joint ruptures and separates. And the Hesch model has looked at MRIs and presents evidence that it may involve not only a separation, but also a posterior glide of both hemipelvis, such that appropriate treatment requires anterior glide of the ilia plus a transverse plane compression. And the standard of care for those patients that have rupture and separation, if it's under 25 millimeters or 1 inch, if it's less than that, then they should be able to heal conservatively, and that would involve a pelvic belt worn down at the level of the pubic joint and the level of the trochanters. And to that, the Hesch model uses a foam under each pelvis to increase anterior glide of each hemipelvis. The Hesch model also has developed treatment for the 16 patterns plus the pubic rupture. In contrasting the traditional model of sacroiliac joint dysfunction with the Hesch model, it's important to note that the Hesch model does, again, as I stated, include the majority of the traditional models, such as anterior ilium, posterior ilium, upslip, etc. And by factually comparing and contrasting the Hesch model with the traditional model, a reasonable conclusion is that the Hesch model is the most significant reinterpretation biomechanically of the sacroiliac and of the pubic joint. And if you would like to learn more about the Hesch method, please see the education section of the website www.heschinstitute.com, and my last name is spelled H-E-S like Sam, C-H. And we have a distance learning program, home study, and we also present seminars, and we'll be going to Netherlands this year. And thank you very much.